So our first lecture in ECG class is going to have nothing to do with ECGs, so nothing specific. It's most, or at least we're not going to mention the term ECG much. But this is just background, sort of cardiac A&P that is really important to know to understand what we're looking at when we start to interpret ECGs. Now, I know that in medical emergencies, you will also be having a cardiac A&P lecture. So I want to acknowledge that there will be some duplication. I don't think that's a bad thing myself, just because I think I could make a pretty strong argument that the two most important body systems for paramedics to understand are cardiac and respiratory. So the deeper an understanding you have of the cardiac system, the better. That being said, Hugh usually gives the other lecture, and if something I say and something he says doesn't quite jive, believe him, he's the expert, okay? So anyway, here's our lecture roadmap. We're going to start with just a kind of a general introduction, go through some anatomy, and then get to the part that really is important to us and when we're talking about ECGs, which is the electrophysiology and very specifically the cardiac conduction system. Okay. Now, if you're following along on your laptop or tablet or whatever, I'm totally happy with that. But this is the one lecture that is really review. And I know that some of you probably haven't taken A&P for a few years, and you're probably sort of thinking, review? I don't remember any of that stuff. That's okay, that's why we're doing it, okay? But still, I think you will benefit from, I'm going to be throwing out lots of questions to everybody about, you know, what's this, what's that, and so forth. And I don't care if you don't know it. But I think it will be better for you if you really try to remember instead of sort of panicking and read it, turning to the next slide and seeing what the answer is. And if you want to do that, that's okay, but I think it'll be a benefit for you not to. So Riley, we're going to start with you. What's the purpose? Let's make it sort of broad here.
Circulate oxygenated blood throughout the body.
Okay.
All extremities.
Okay, that's a great answer. What else, Kyle? What else? Let me help you out. What else besides oxygen? Is it just oxygen?
Like nutrients.
Okay. Okay.
Like glucose.
Glucose?
Yeah.
Excellent. Okay. Koa, what about you? Those are two great answers. How can you? It's harder as we go further along. But how can you add anything to that?
So like more movement of like waste. And
Oh,
filtration.
nice answer. Excellent. Excellent. Anybody else want to add anything before?
Gases.
Excuse me?
Gases.
Absolutely, gases, okay? So all living cells require metabolic substrates, which we've mentioned, oxygen, amino acids, glucose, so nutrients. And then, as Koa mentioned, we also need a way to remove waste, so byproducts of metabolism. So if you think about, sort of again, very broadly about living creatures, well, who has a heart and who doesn't have a heart? Without getting too into the weeds here, if you think about it, when we're talking about single cell organisms, the whole cell has this direct connection with the environment. So there's no reason for single-celled organisms, for example, to have hearts, because they can just move things in that need to be moved in via diffusion and move things out via diffusion. But when we talk about larger organisms, there has to be some way to move these substances around. And so larger organizations have developed these sophisticated systems of blood vessels. And exchange of substances occurs between blood and environment, and then the blood carries these things to the cells, or cells to blood, blood to environment. So if we're thinking about blood to the environment, in a healthy body, where is the exchange, or which places is the exchange between blood in the outside environment made? What can you think of? So Andrew, can you think of any place? Like
Skin.
oxygen for skin. Great. Okay. Well, that's a good one. Grace, what about you?
Lungs.
Lungs. Excellent. Okay. Natalie?
Capillaries.
Definitely capillaries, blood to the cells. Excellent. Good. So what about, Cody, what about outside environment? What about that glucose and nutrients and stuff? Where's that exchange between blood and the outside environment made?
What do you mean by outside environment? Like outside?
Outside.
I mean like when you're working off sweat or something, you're expelling
Excellent.
stuff.
Yeah, that's very true. But what about those nutrients? We don't get our nutrients from them. They have to come from outside. So Chris, where do the nutrients, how do we get them into our body? And where do they meet the blood?
Intestinal tract.
There you go, GI tract. Yeah, okay. So exchange between blood and outside environment occurs in several organs, and we're not, again, we're not being, we're just talking very generally, but lungs, GI tract, kidneys, and skin are some examples. And Cody made an excellent point. In fact, I'm going to ask him to answer this question because he pretty much did already. While skin serves as a site for exchange of water and electrolytes, we're talking about sweating, it also serves to exchange what? Why do we sweat? What's really happening there with sweat?
Everybody's trying to lower temperature.
Yeah, okay. So the other thing, besides all the oxygen and the nutrients and everything, we also need our cardiovascular system to keep a constant temperature. And so we use the blood, for example, when we need to get rid of heat, we'll use the skin to sweat and exchange heat, okay? So in summary of our introduction here, when we're asked the question, well, what is the purpose of the cardiovascular system? The ultimate purpose is to facilitate exchanges of gas, fluids, electrolytes, large molecules, and heat between cells and the outside environment. Okay, makes sense to everybody? Okay, yeah.
When you say outside environment, you're just referring to anything outside of
Outside of the body itself.
cardiovascular system.
No,
Outside
outside.
the body.
No, I think the point here is all the cells of our body, the outside environment. We need to get things. We need to eat lunch. We need to drink water. We need to breathe in oxygen. We need to get all of these substances into the cells of the body. And the point here is, well, the cardiovascular system is, if you will, the go-between. How we do it, how we get things in, and how we exchange things out. Make sense?
Yep.
Okay. Good question. Okay, so let's just talk about some general anatomy, and this is where we're really, I think, going to get into the review. And I don't need to say anything that says, we're big about, pumps and tanks and pipes and tubes and so on. So enough said there. Okay, so where are we here? Spencer, I think we got up to you. What are the four chambers of the heart?
The left and right ventricles.
Good.
The left and right
Perfect. Atria. Yeah.
atrias.
Yeah. Atrium is singular and atria is plural. Yeah. So left and right atria, or right atrium and left atrium. Okay. So especially some of this initial basic stuff, which I understand it's easy for me to say basic, and you may have taken A&P, 3 or 4 years ago, is stuff that if it feels a little rusty to you, and I'm sure it does to at least some of you, make sure that pretty quick you have it so that it's so obvious to you, okay, that this is the kind of knowledge that should just become so second nature, not just for this class, but in general, okay? So, superior vena cava, the blood enters there, goes into the right atrium, right ventricle, okay? And where does it go from the right ventricle? Okay, and say it again, please.
Pulmonary veins.
And where does that go to?
lungs.
Okay, so lungs, then it comes back to the left atrium, left ventricle, and out through the aorta. Now, there's a significant difference in capacity, if you will, between the left side and the right side, and specifically the left ventricle and the right ventricle, okay? And of the two, here's a difficult question. Which one is more muscular?
The left one.
The left
because
ventricle.
That's going to the whole body, so it has to pump harder.
Perfect. Two answers for the price of one. That was great. Okay. So left ventricle, the Shaquille O'Neal of the whole thing. You know, this is the really large muscular part, and then the right ventricle, and exactly for the reason that Anne stated. And here is a more real one. Okay. So, Riley, back to you. What are the 4 valves and where are they located? And just do the best you can, and then Kyle's going to pick up the slack.
It's like bicuspid,
Okay.
tricuspid, bicuspid, and then there's the mitral valve,
Okay.
and I think that shares a name. There's 2 names for it. And
Okay.
then, the aortic valve.
Okay.
And pulmonary valve, I think.
Yeah, you did pretty well. Okay, so Kyle, so that's a great beginning. That was well done. Okay. So we have 2 valves that sometimes we call the AV valves. So what does AV stand for?
Atrioventricular valve.
Yeah. And so, and I'll dump this one question on Kyle. Which are the 2 AV valves?
The tricuspid and the mitral.
Okay. So we'll just jump into it here. So the AV valves, by the way, why are they called the atrial ventricular valves? Co-op, why are they called the AV valves? What does that tell us about their location?
They're above, so they're in the atrium.
Say it again?
They're in the atrium.
They're
Lead from the
between, they're
between
between.
atrium and ventricles.
Right, there you go. Okay, so the AV valves are between the atria and the ventricle. So on the right side, we have the tricuspid. On the left side, the bicuspid, also called the mitral valves. And then the other 2, if you want to put them as a group, are the semilunar valves, and those are the valves that are leaving the ventricles. On the right side is the pulmonic, and on the left is the aortic. So, in this case, a picture is what we really want to see. So the 2 AV valves are between the atria and the ventricles. Okay. So tricuspid, that's the right AV valve. And mitral or bicuspid is the left AV valve, okay? And then the valves that leave the ventricles are the pulmonic that goes, where does that go, Nat or Grace? You were the one that said that. Where does
The lungs.
to the lungs? And then the aortic valve, and Andrew, where does the aortic valve go to? It leaves the left ventricle, and then where does that blood go?
Goes to the aorta and then throughout the whole body.
Perfect. Okay, so here's a picture. In fact, I'll show you what we're looking at here. The mitral valve and the left AV valve. So we're looking at sort of a blow-up of this valve. What's all this stuff? Why do we have those? Natalie, do you recognize these, which are kind of muscle that might help you? And then these? What's that about? Do you remember?
Definitely recognize them.
Okay.
I do not remember what they're called though.
Do you remember what the purpose is?
It's to help with facilitating the pumping of the blood.
Mm-mm. No?
No, I do
No? Who? Anybody? Yeah, Spencer.
Aren't they called the papillary muscles?
Papillary muscles. You remember what these are?
The chordae tendineae?
Perfect. Chordae tendineae. And if you want to get the trifecta here, what's the purpose?
They help keep the valve closed when the pressure inside the chamber is.
Correct. We want to prevent backflow, okay? So for example, remember AV valve. This is, so AV, Cody, tell us again what the AV means here.
Atrial ventricular valves
Okay, and the AV valves, where are they located? Between what and what?
in the atria,
And,
in between the.
say it again?
What do you mean by in between?
So it's, the AV valves are each of them are located between two different chambers of the heart.
The atrium and the ventricle.
Perfect, okay. And in this particular case, because it's the mitral valve, it's located between the left atria and the left ventricle. Now, what happens is that when the ventricle, we're going to talk a lot about this in a few minutes, when the ventricle fills with blood, this AV, so in order to fill with blood, this AV valve will be open, okay? Because the blood's going to flow from the left atria to the left ventricle. Then it closes, and huge pressure happens when the ventricle pumps. Now, what we don't want to have happen is for that pressure to blow open the valve and the blood go back up, ventricle to atrium. That's a bad thing, okay? And these are preventing that from happening. They're preventing the valve from blowing backwards, okay? They're tying it down with the chordae tendineae, okay? Okay, so, Koa, let's start with you, and we're just going to go around and identify all the structures in the heart, and the very first one is going to pop, the name is going to pop up here, and we're looking at this very large vessel there. What is that?
Aorta?
Yeah, say it with conviction.
Aorta.
There you go. Okay, Andrew, what is this one right here?
Supravena cava,
There you go.
superior vena.
Yeah, superior vena cava. Okay, I kind of like that though, superior vena cava. And then what, Grace, what's the next one there?
Pulmonary valve.
Yep. And then Natalie, the next one is pointing here.
Is it the AV valve?
Yeah, it is. And it looks like it's on the right side, so which,
Tricuspid?
yep, okay. And then, Cody, we're talking about this large, no, we're not, we're talking about this, so it's gonna be this one, it's this chamber here.
Is that the right atrium?
It is the right atria. And then, Chris, this large vessel here. Yep. And let's see, what is it pointing to? Okay, so Spencer, we're talking about the chamber here. Okay, and Anne, we're talking about, yeah, okay, so we're talking about these muscles here. Correct. And so remember, that's what we said. The AV valves have these papillary muscles that are tying down the AV valves to prevent them from blowing back when the pressure gets great in the ventricles. Okay, and then who's next? Who's the lucky person next? Riley, this is the hardest one of the whole thing. It's this little tiny opening there.
Oh my gosh, I know what it does too. and
Oh,
why
just
it's
say what it
there.
does, because the name is not important.
Wait, I think I do. I
Okay.
think that was, that's that little mark, it's like, it's some little fetal attribute, right? It's
No,
like-
it's
No,
not.
it's not.
I know what you're talking about, but that's
Oh, I'm
not what
wrong.
it is.
Well, okay,
Anybody
so what is
know?
it?
Anybody know? It's an opening at the base of the aorta, Spencer?
Is that where the oxygenated blood goes to the heart?
Ding, ding, ding. Yes, it is. Orifice, and you don't have to remember, it says the orifice of the coronary arteries. All you really need to know, it's a little opening that goes into the coronary circulation, which surrounds the heart and feeds the heart, and that's where the heart gets its own blood, okay?
On the pulmonary valve or the?
No, it's on the aorta, and why would that be?
Behind it. Yeah,
Why
because
would it be on the aortic valve instead of?
Because the pulmonary valve is an oxygenated, the blood in the pulmonary valve is an
Yep.
oxygenated receptor.
Yep, this is right here, just going out of the aorta, the blood is as oxygenated as it ever gets, and that's what we want to give to the heart. So that's why.
I would not have that. I'm sorry.
I know, but you know what? That's about typical. You know, one person who probably either really loved A&P or just recently took it or both gets it.
Be average.
Okay. So let's see, who's next? Kyle? It's this chamber here.
The left ventricle?
left ventricle. And then, let's see, which one is it? Okay, and then Koa, it's this valve here. It kind of goes behind and goes out there.
Aortic.
Yeah, there you go. Okay. And then, Andrew, we've got our final valve, which is that one there.
Mitral valve.
Perfect. And Grace, we've got our final chamber, which is here,
Left atrium.
left atrium. And Natalie, our final large vessel.
Pulmonary.
Yep, pulmonary trunk, but that's fine. Okay? Okay. Now, let's see. So, Cody, what I want you to do is you can start anywhere you want. You could start with the aorta if you want, or actually any place you want. And then just say what comes next. So if you start, this is the direction, oh, I see, with the vena cava. You can't start anywhere you want. Start with the vena cava. The blood goes through the vena cava. What's the next place it goes? What's the next place it goes after that?
Okay, so it goes from the vena cava, hold please, like the superior vena cava?
That's a really,
Or where?
I didn't divide it up. I
Okay.
just said the vena cava,
it's
so
gonna
we'll
go-
say inferior and superior together.
It's gonna go to the right atrium,
Good, and from there, where's it gonna go?
left, or right ventricle.
Good, and where does it go from there?
The pulmonary trunk.
So pulmonary circulation,
Yeah,
this is a little more
pulmonary
general.
circulation.
Okay, and after it goes through the lungs and comes back into the heart, where does it go?
Left atrium,
Good,
left ventricle,
good,
and then to the systemic circulation.
good. And which is the large vessel that from the left ventricle goes through a large, very large vessel
Oh,
to
the
get?
aorta.
Perfect, okay. So there it is. Now, if this is another one of those things that if you're sitting there going, ooh, I am so glad she didn't ask me that, make sure you learn this, because this will help you, again, not just my class, this is stuff that should be really like easy peasy for you, okay? And then here's sort of an overview. And again, even though this is the heart together, they've been separated out. Now, we like to say, because it's true, is that the right and left ventricles are in series, okay? And what that means is that this is the way it goes. There's no, until we get to, say, the systemic circulation, there's no other way to do it. There's no other way to get from the right side of the heart to the left side of the heart other than going through the pulmonary circulation, okay? There's no way to get from the left part of the heart to the right side of the heart other than going through some part of the systemic circulation, okay? So what does that mean? Think about it for a minute. What does that mean in terms of the volume that is in the right ventricle that is expelled for one contraction on the right side compared to the left side? I think you've got the right answer.
It's less than.
No, actually, it's
The
all
same?
exactly the same. So if you think about it, I mean, just think about, don't worry about hearts and circulations and all that. Just think about a big circle going around. It's all going like this, okay? The same amount is going through all the time. So when we're talking about the stroke volume, say, usually we're talking about the left ventricle because that's what we're most concerned about. The truth is, the amount that gets expelled from the left ventricle is the same as the amount that gets expelled from the right. As opposed to, when we're talking about the systemic circulation, now each system is separate. We've got multiple systems, so that once it leaves the aorta and it goes through, say, this blood could just go to the kidneys and then go back to the heart without, say, going into the legs or the GI tract or whatever, okay? So what we have here is we have all these systems in parallel, okay? So we could, for example, if we felt like it, say, no, we're going to shut down all of the parallel circuits, we don't quite do this, and send it all to the kidneys. Or let's shut down the legs and send it to the head. You see what I mean? The body can adjust how much blood goes to various parts of the body. Why is that useful? Why is that useful? It's happening all the time. We're doing it all the time. We're adjusting how much blood goes to certain areas of the... So, for example, do you think more blood is going to your GI tract now or right after breakfast? Cody?
So it's gonna be going right after breakfast.
Yeah.
And like it's, like if you're running, for example, it's gonna go more to your legs than.
Yeah, and
your
lungs
GI or
and,
whatever.
yeah, exactly. So the body can adjust how much blood goes to each part of it. Okay, we've already mentioned this, so I'm just gonna, Chris, do you remember, what is the third circulatory circuit that begins and ends in the heart? We have the pulmonary circuit, we have the systemic circuit, and then we have the mysterious third circuit.
Coronary.
Brilliant. Okay, there you go. The coronary circulation. And we already mentioned that when we were talking about the little orifice at the base of the aortic. So here is the a picture of the coronary circulation. And in this class, now if we were going to become cardiologists, for example, we would, at this point, we would stop and who knows, I don't really know, but maybe spend several weeks just talking about what's on this slide. But in this class, you only need to know 4 different vessels, okay? So, the first one is the left main coronary artery. It's very, very short. It's barely there at all because it bifurcates almost immediately, okay? It comes out of the base of the aorta with the most oxygenated blood and comes right here, and then it bifurcates. So the left main is just a really small part, okay? Because it immediately bifurcates into 2 very large arteries, okay? One of which is the left anterior descending artery, which does exactly what it says it's doing, okay? It descends down the anterior wall of the left ventricle, okay? Left anterior descending. And you'll hear people, the abbreviation is used a lot for this, the LAD, yeah.
What was the LAD that you just said was an important one?
I'm sorry, one more time?
What was the artery you just said?
The left anterior descending artery. So the left, right there, okay? And then there's, you know, this picture is a little bit deceptive because there's multiple branches coming out from it. But we're not interested in the multiple branches. We're just gonna learn the main arteries, okay? The second bifurcation is of the left main, is the left circumflex artery. And you'll hear people call that the LCX. So the LAD and the LCX. You're more than welcome to use the abbreviations. The only rule I have about abbreviations is if, for example, Andrew is sort of talking on about the LAD and the LCX, if I turn to you and say, what's the LAD and the LCX, you have to know what the abbreviations stand for. But you're very welcome to use them, okay? In a minute, we're going to see the back of the heart, because what happens with the left circumflex is it circles around the back of the heart, and we'll see what happens to it in a minute. Now, the right side, what do you think? Does the right side need more or less arteries than the left side? Less. And why, Grace? You're correct.
Because it's not going to the bottom, it's just going.
Well, none of this is going to the bottom. I'm saying, let me rephrase my question. Does the left part of the heart need more blood or less blood than the right blood of the heart, the right side of the heart?
It's muscle overall.
Yes, correct. Okay. Remember, this is the really muscular side of the heart. So that's why we have two really major arteries. On the right side, there's just one major artery that then makes multiple branches, and that's the right coronary artery. Okay? Now, if we look at the back of the heart, what happens there is that here's the left circumflex, which started on the other side. It was the initial bifurcation of the left main. It comes around, it's this here, and it drops down to the bottom of the heart. So the left circumflex feeds the posterior and the inferior walls of the heart. The right circumflex does the same thing, but from the other side. It circles around and it drops to the bottom. So if I were to ask you, of the three main arteries, left anterior, left circumflex, right coronary artery, which two feed a similar area of the heart, you would sort of say, logically, left anterior descending and left circumflex, because they're both left. But that would be wrong. It's the left circumflex and the right coronary, because both of them circle around the back of the heart and then drop to the bottom. Okay? And that's, yeah, okay. So, Natalie, so let's go through that again. The aorta, coming out of the aorta, what are the two big main coronary arteries?
The left main coronary artery and the right main coronary.
Yeah, except you're exactly right. Although typically we call the right coronary artery just the right coronary artery, because there's not that big bifurcation. It's just a matter of naming. It doesn't mean very much. And then, Chris, the left main coronary artery bifurcates into two large arteries. Do you remember what they are?
Left anterior descending.
Eh, yes.
Okay.
I was confused about names, so I'll go with Chris. Yes. And who remembers the second one? Left anterior?
Left circumflex.
Perfect.
Yeah.
Okay, the LAD and the LCX. Okay. And then what happens is we go to smaller arteries and capillaries, we go to veins, and then we come back to what's called the coronary sinus, and then back into the right atrium. Okay. That's everything you need to know in this class about the circulation of the heart, okay? Except for the next slide. So, one final note, and I just think this is really useful, a really useful fact for paramedics to know. There are some parts of the body that can go for pretty long periods of time without oxygen. Okay, the heart cannot, and we all know this, right? We all know about CPR. The reason is because there's no storage capacity for oxygen any place in the heart. The blood just goes through it. There's no good storage, and so it has an absolute requirement for the aerobic with oxygen production of ATP, because there's very little anaerobic, no oxygen way to produce ATP. Okay, moving along here. I sort of lost track of where I am, but Spencer, we'll go with you. What are the tissue layers of the heart in the pericardium? Do you remember all that complicated tissue layer stuff?
There's an endocardium,
Mm-hmm.
myocardium.
And the endocardium, where is that located relative?
The endocardium inside.
Good, endo, right, excellent, good,
And the
okay.
myocardium is the big fat muscly part in the middle.
Good,
And
then it gets complicated. Yeah.
epicard, I don't think it's the epicardium, exocardium.
No, it actually is the epicardium, but who knows? Actually, I think I'm just going to move through this. So endocardium, and we'll see a picture in a minute, so it'll make sense. Endocardium lines the inside of the ventricles and atrium. Myocardium is muscle, is the muscle layer. And then what we get to is what's called the pericardium, which actually has two different layers in it. The epicardium is the visceral layer and the parietal layer, and then the very outside is the fibrous pericardium. So because that's confusing, we're just going to jump right to the picture, okay? Okay, inside of the chamber of the heart, let's see, here they have it, atrium, okay? Endocardium is the layer that lines the inside of the atria of the ventricles. Myocardium, the muscle. And then we've got this funny layer where we have remember the serous pericardium. Remember, this is a double layered something with fluid inside, okay? That's what we mean by a serous pericardium or serous layer. The visceral layers on the inside, the parietal layers on the outside, and inside is pericardial fluid. On the outside is this fibrous layer for protection. Now, the main reason I make a big deal of this, because in a way it doesn't have that much to do with ECGs, has to do with that layer of fluid. What's the deal with that layer of fluid and something that you might be treating at some point? Yeah.
Pericarditis.
Pericarditis, that's a great answer. What's another one?
Cardiac tamponade.
Ah, excellent. So what is cardiac tamponade?
It's when, I believe it's when it gets inflamed, and so the heart can't beat and perfuse as well.
You're pretty close, but not quite right. What happens as far as the amount of fluid when somebody has a cardiac tamponade?
Accumulation of fluid in the
Yes.
parietal cavity.
Okay, so tamponade is a condition in which too much fluid accumulates in that area. Remember the picture we saw of a healthy one is there's just a little tiny layer of fluid. Why is it even there? Why do we have to fuss with fluid around the heart? What's the point?
Isn't it for friction purposes?
Yes, correct. Remember, the heart is constantly moving in and out, and it's lubricating the heart. So you're correct. It's for to avoid friction. Yeah. Now, if something happens that too much fluid builds up in that in the parietal cavity, it can't expand because of that fibrous pericardium, the fibrous layer that encloses the heart. So the only thing it can do is push in, okay? Why is that a problem? Why is that a problem for somebody who has a cardiac tamponade?
Keeps the ventricles from filling.
It keeps the ventricles from filling. Eventually, if it's too dramatic, it will actually stop the heart from beating. Okay. So again, another little picture, too much fluid pushing in on the heart. The severity of cardiac tamponade depends on two things: the rate of the buildup of fluid. So what do you think is worse? What do you think is harder for the body to adapt to, if there's a sudden buildup of fluid or a gradual buildup of fluid? Yeah, sudden, okay? Why might there be a sudden buildup of fluid?
Trauma.
Say it again?
Trauma.
Yeah, absolutely, because of trauma, okay? And then also the ability of the pericardium to stretch and accommodate the fluid, okay? So let's talk about that. So if the buildup is happening very quickly, even 100 milliliters extra may cause signs and symptoms of shock. If it builds up very slowly, which it can do because of infection and disease process, the body can actually, and this would be extreme, can take almost a full liter and show no signs and symptoms. But that's if it's very gradual because of illness. And then causes of stiff pericardium, I'll just let you read that. Here's a picture. So before we move on, how is it treated? Excellent. And what does that mean?
Put a needle to your chest essentially, and sample the fluid.
Yeah, and then we're, right, okay. Do paramedics ever do that?
Yes.
Yeah, there are some, it's pretty rare, but there are some protocols that do include that. So. Okay.
I just randomly flipped over in
To
our
the-
lab book one day.
Which book?
Our lab book,
Oh, okay.
the lab we're gonna do later, just the day I got it, I just opened it, and it was pericardiocentesis. I
Well,
was
there
like,
you go.
people actually do this in the field?
Yeah, it's
crazy.
pretty, well, the only times I've known it to, I know, and I don't know, this may be out of date. There used to be some of the services, we used to have interns that were, up near Olympia, and they had it in, but they were using it, the only time they ever used it was like at the very end of the code. You know, and that was sort of silly. I don't know,
I
I
was
don't,
just,
yeah.
I'm sorry, I was just Googling it, it was like 24% of all the programs in the country teach pericardiocentesis as
Mhm.
far as like your
The
actual
question
disease.
is how much they actually use it. That's
Yeah.
some- Yeah, so when I went to paramedic school, which was a long time ago, and what we did, what you do is so much better than what we did. What you have is a cadaver lab, which, you've heard of the cadaver lab, yeah. What it used to be, and I'm glad it has changed, but when I was going to paramedic school, instead of dead people, we used live pigs, and it was called the pig lab. It was up at OHE. It was pretty awful, but it, you know, they weren't like live squealy, squirmy pigs. They were. It was still pretty awful. What they were small pigs, and they were anesthetized, and there would sort of be an anesthesiologist watching over the pig. But we got to practice on the pigs, and I remember doing a pericardial centesis. And I can tell you, it actually was pretty, on this pig, it was pretty straightforward. You go right under the sternum, you head for the left shoulder, you've got a syringe that you're pulling back all the time, and when you pop into the pericardial sac, it suddenly fills up with fluid, and you could see, again, this is really awful details, graphic details, but I don't remember how it had been done, but a cardiac tamponade had been induced, and the heart rate, it was almost no activity in the heart at all, and all of a sudden, kaboom, it started beating again. So I can assume it would be effective. But that's the only time I've ever done it. Spencer, you had a question?
I did, I'm just processing. Okay, so you said that your interns up in Olympia, would do this at the end of a code.
What was the reason?
I mean, does that mean they were basically dead and you're just like, hey, let's practice this skill, or was it like?
No,
like,
it was a little more sensible than that.
Okay,
Not
okay.
The reason was because cardiac tamponade, do you know what pulseless electrical activity is?
I've heard
It's,
it,
yeah,
So
it's
it's
so,
just
it's
kinda-
so when you're seeing electrical, like you look on the monitor and you're seeing, who knows, maybe a
Right, but there's
sinus
no like
rhythm.
discernible pattern.
No, there is a
Well, there is
the
a
point is there
discernible
is an
pattern.
organized rhythm, but you take the pulse and there's no pulse. And actually cardiac tamponade is a reason for that to happen, because if you think about it, let's say the person hit their chest on the steering wheel column or something like that, and it creates a tamponade. Now all of a sudden there's some pressure into the heart, and the heart itself isn't dead yet, it's still doing fine. Let's say it's a healthy heart. It's preventing the mechanical activity, but the electrical activity is still occurring. So when you look on the monitor, it looks fine, but there's no pulse. So it's a very legit, I mean, my suspicion is if you see it done, it would be done in say, the emergency room, where a doctor is doing it for that reason, that there was, trauma to the chest, and they suspect. So
That's
that
not
was-
the only reason for PEA though, right? I
No,
mean, there's
no,
really a bunch
no,
of reasons.
no.
We had a
But
patient with PEA.
no, there
else,
are other
yeah.
reasons, and we won't go to that now.
Right.
But if it comes down to, does it make sense? And again, I know they still do. Does it make sense for them to have done it? I could say no, because my guess is by the time they got to that point, the person was so dead, no amount of
Right.
pericardial centesis was going to save them. So
Okay.
anyway. Okay, how are you guys doing? Do you want to break now or in a little bit? You ready for a break? Okay, so it's 9:50 now, 10 minutes? Enough? Okay, back in your seats at 10 a.m. Okay, so let's get going. So we're just gonna jump in and go some quick definitions. Riley, what is cardiac cycle?
Just say that, I mean, take a guess here, but cardiac cycle being like the circulation of blood throughout the body, like a full cycle from, the.
Actually not. So we're gonna, I understand why you're saying that, because that's what we've been talking about.
Sure.
But anybody else wanna jump in, cardiac cycle? Yeah, Kyle?
A combination of both systole and diastole.
Perfect, okay. So that's exactly right. I said it a little different, but what you said is exactly right. The period of time from the end of one cardiac contraction to the end of the next. Could also be from the beginning of one to the beginning of the other. It's one total diastole, one total systole, which begs the question, Koa, what is diastole?
Is when the heart is at rest, so it's fine.
Yep. So when the myocardium is relaxed and filling and coronary perfusion, that's when the blood is going around the heart itself also occurs. And then, Andrew, what is systole?
Period of time when the myocardium is contracting.
God, you have such a nice way with words.
Thank you. Oh, that's exactly.
Oh, but it was not a very unusual statement. So, let's see, Grace, what do you think? When does the coronary circulation receive more blood, during diastole or systole, and why?
Diastole.
Okay, you're correct. And why? Why do you think?
Because that's when the myocardium is relaxed.
That's exactly right. So during diastole, the myocardium is relaxed and the blood is really able to flow freely through the coronary circulation. During systole, blood vessels become flattened because of the contracting muscle. Now, this is a slight exaggeration, and the reason I say it's a slight exaggeration is the area of the heart where this is mostly true is the left ventricle, just simply because there's so much muscle there. It doesn't matter quite so much in the other areas of the heart. Now, so we know that coronary perfusion, again, we're talking about the coronary circulation, occurs during diastole. We also know that when the heart's beating very fast, tachycardia, fast heart rate, that diastole shortens. So what do you think? Does this mean when the heart's beating really, really, really fast, does the heart not get enough perfusion around itself? And again, I'm talking about the coronary circulation. Any ideas? Anybody want to jump in?
Yes.
Sometimes.
Meaning, yes, what's the question? Does this mean the heart doesn't do that? Good. Okay, one yes.
Yes, because when it's beating so fast, it doesn't have time to refill.
Okay. So actually, sometimes, the answer is sometimes, okay? So in a healthy heart, like if a bunch of you went and ran around the building 5 times as fast as you possibly could, there's no doubt that your heart rate would go up. But because I'm making the supposition that you're all in pretty good shape, you're not really going to have too much of a problem with not enough filling in the heart. Because what happens in a healthy body, we have something called active hyperemia, which means the more blood flow, the more increased metabolic activity, okay? So then what happens is increased oxygen consumption is going to cause the vessels to dilate, and even though the filling pressure, even though there's less time to fill, actually filling will occur and good cardiac perfusion will happen. So short answer there is, in a healthy heart, the heart is able to compensate for that. But when somebody has coronary artery disease, the vessels become stiff. And so when this really happens, when the heart really starts becoming ischemic because of a fast heart rate, is when we have a dangerous tachycardia with somebody who does not have a healthy heart. So that got a little garbled, but see if we can straighten that out. Chris, you had a question.
Yeah, oh, sorry. I have to figure out what the question was. So something about tachycardia and max heart rate as you age, something like that.
Oh, that's true.
So as you age, max heart rate
Yes,
drops
Yes.
slowly.
Yes.
So does that also have something, like you can still be healthy at an older age, but because your max heart rate is lower?
I don't think the two are connected, it's just, that as you say, your heart is less able, to beat fast. And typically, what we think of as the max heart rate, and we're not talking about things like ventricular tachycardia, we're talking about sinus tachycardia, so healthy tachycardia, is 220 minus the person's age. So, and again, that's a very ballpark kind of figure. So the older you get, it's true, the less able, as you run around the building, your heart will, you're less able to bring your heart rate up. Okay. Atrial kick, where are we here? I can't remember. Natalie? What's atrial kick?
I'm guessing, is that like when the blood is leaving the heart and going out through the atria and like pumping out, so like the systolic pressure?
Some parts of that are correct. So
Total
when,
guess.
so when the blood leaves the atria, where does it actually go? Into what?
To the arteries?
No, it goes atria and then
Ventricles.
into the ventricles.
Yeah.
So first of all, just to be clear, when the blood doesn't leave the heart, when it leaves the ventricles. But you're correct in that atrial kick does have something to do with how the blood gets from the atria to the ventricles. So, Cody, do you know what atrial kick is?
I do, because I just read it, but
Go
I don't.
for it, that's fine with me.
I don't. Beforehand, I had no idea, but I can tell you it's the amount of blood added to the ventricular and diastolic volume of ventricular contraction.
Okay, good reading. Okay, so let's talk about it for a minute and we'll get questions. Okay, so what we're distinguishing between is passive filling of the ventricles and active filling. So blood comes into the atria from either the systemic system or the pulmonary system, and it goes through the atria into the ventricles. And so the ventricles get more and more and more full. A large part of that is what we call passive filling, meaning it comes in, say, through the vena cava, flows through the right atria, and just the blood flows right down into the right ventricle with just the pressure, the blood pressure pushing things forward, the blood pressure of the body pushing things forward. And that's what we think of as passive filling. The blood just flows through the atria, flows into the ventricles. Then at the last moment, the atria contracts and pushes that last little bit of blood into the ventricles. That's the atrial kick. So we have passive filling and we have active filling. Passive filling is just created by the pressure of the blood flowing through the body, okay? And then active filling is of the ventricle is created by the atria contracting and pushing that last bit of blood into the ventricles. So, for example, here we have late systole, and what we're talking about, meaning that the ventricles have just contracted. This is late ventricular systole. You can see the ventricles are empty. Now, they never totally get 100% empty, but on this picture they are, okay? So now we're moving through the cardiac cycle. We need to fill up the ventricles. So the AV valves open, and what's happening is that blood is coming into the atria, not shown on this picture, and it's just moving forward because of the blood pressure in the body. That's the passive filling, okay? So this is still diastole, and the ventricles are pretty full, just by passive filling. The atrias haven't done anything. They just sort of sit there. At the very end of diastole, we have what we call atrial systole, meaning the atrial contract, and they contract and they push in that last little bit of blood, okay? And that's how we get full ventricular filling, okay? So we're going to go through that again in a little more detail. So diastole, heart is at rest, myocardium is relaxed, the AV valves are open and the atria and the ventricles are filled, passive filling. And then the semilunar valves are closed. Why at this point? Why are they closed? Why are these the valve into the aorta and the valve into the trunk closed?
There's more pressure in those, like, the arteries than there
Oh.
is the ventricle.
Okay, yeah, so the pressure from the aorta, from the pulmonary trunk are pushing back on these valves and they shut. Because what we want is for the ventricles to fill up. We want a nice big, filling, so when they contract, a lot of blood gets pushed through. So what happens is this valve is open, the blood goes in and is filling up, these valves are closed, the ventricle gets fuller and fuller and fuller and fuller, okay? Then what happens is the atria contract, causing atrial kick, okay? At that point, the AV valves close, okay, and we don't see the chordae tendineae here, and the ventricles contract, okay? These valves now open because of the pressure in the ventricles pushing into the aorta, pushing into the pulmonary trunk, okay? Questions? Make sense to people? Okay? Okay, what is preload? That's a term that you will use. What's preload? Anybody know? Okay, preload, it's kind of a funny definition because sometimes it's defined as a pressure and sometimes as a volume. The pressure within the ventricles at the end of diastole, commonly called end diastolic volume. End diastolic volume. So it's the volume of blood that is in the ventricles at the end of diastole just before the ventricles contract. This is the moment where the ventricles are filled as much as they will be during that single cycle. Passive filling has happened, atrial kick has happened, you've got the most volume, that's the end diastolic volume. Okay. Now, what is slightly confusing is that sometimes preload is described as end diastolic volume. And if I say to you on a test, what's preload, and you say end diastolic volume, great answer. Okay. Sometimes it's defined as the pressure within the ventricles of that volume pushing out, end diastolic pressure. If you want to use that, that's fine. Typically, as paramedics, we like to think of preload as an amount, as a volume. Okay. But I don't want you to get confused if you hear it defined as a pressure. Preload influences the force and the amount of the next contraction in a manner described by Starling's law of the heart. Well, there's a mouthful. Who remembers what Starling's law of the heart is? Anybody remember?
Isn't it something to do with like preload is the same as stroke volume, or they're related?
They are related, but that's not Starling's law of the heart. Okay. Anybody remember? Okay. So Starling's law of the heart, what it means is, suppose, when do you think a healthy person, when do they have more volume? When they're exercising or when they're resting?
Exercise.
Okay, so you go out and you run around the building 5 times, okay? And now you're going to get a whole lot of preload, meaning that you've got a lot of volume in your heart right before it contracts. In a healthy heart, what Starling's law tells us is the more volume in the ventricle, the stronger the contraction will be, okay? So in a healthy person, you're exercising, you got lots of blood in the ventricles, your heart is really going to push it through. Then you go home, you fall asleep, you're resting. Now there's not so much preload and you don't need it so much. So at that point, your heart's kind of taking a break and there's not so much. Then in a healthy person, what happens is that there's less volume, so less pressure. Okay? So the more end diastolic volume, the bigger the preload, the greater the contraction. The less the preload, end diastolic volume, the less the pressure. Okay? The less the contraction. Make sense? Okay. Okay, what are some factors that influence preload? Anne, can you remind us what preload is, please?
It's the pressure or volume at the end of diastole.
Correct, the end diastolic volume, and that's significant because it's the time when the most volume is in the ventricles. Okay. Spencer, can you remind us what atrial kick is, please?
It's when the trias contract and kick out the last little bit of blood that's in the.
Correct. So, Chris, what do you think? If the atria kick goes up more, do you think the preload is going to go up or go down?
You should go up, right?
Yeah, absolutely. Because the more the atria are pushing in that last little bit of blood, the more blood goes in there. So the stronger the atrial kick, the more the preload. So Kyle, when do you think that your atrial kick is at its highest? When you're running around the building 5 times or sleeping?
You're running.
Yeah. So that's one of the ways that a person who's healthy compensates when they need more blood, is that the atrial kick goes up, the preload goes up. And Starling's law of the heart tells us what when the preload goes up? What else goes up? Yeah, Cody?
The higher the preload, the higher the contractions.
Perfect. Okay. What about ventricular compliance, meaning the ability of the ventricle to expand? Okay. Now, typically that's not something we think of with a healthy person because the ventricle is plenty compliant, but people who have various forms of illness, their ventricles may become stiff. Okay. So ventricular compliance, what do we think? So Andrew, if the ventricular compliance goes up, the ventricles has a greater ability to expand out. What do we think? Preload goes up or goes down?
Goes up.
Yep, absolutely goes up. And conversely, somebody has, their ventricles become stiff. They don't have as great an ability to expand their preload. Okay, Grace, you get the tough one. Heart rate. What do you think is going to happen to preload if the heart rate goes up? It's going to go up or go down? Okay, Grace says it goes up. Any other takers?
I think it'll go down because it doesn't have as much time for the ventricles to fill.
Okay. Anybody else have an opinion?
I venture to say it depends on the person and what they're doing.
Yes, nice. Or it doesn't necessarily depend. It depends is the answer, but not necessarily on what they're doing. It probably depends on the health of their cardiovascular system. If nothing else changes, then Grace is exactly right, okay? So I think you said it goes down, right?
No, she said.
Oh, then, sorry, Natalie's right, okay? Tachycardia can lead to decreased preload because of decreased ventricular filling times. It's not enough time, not as much preload. However, healthy individuals can compensate so that the preload remains constant or even increase slightly so tachycardia is not a problem. You can increase your atrial tach, you can increase your ventricular compliance, you can do all the things that conditioned people do so that even though their heart is beating really fast, they still get a good filling in their ventricles.
So with ventricular compliance, is that going to be affected by atherosclerosis? Or is
It wouldn't be atherosclerosis. I'm on thin ice here because I'm sitting here going, okay, now what exactly do I? But atherosclerosis is more specific to this. I don't know, Jamie, you're sitting here, do you have the answer?
Not my kind of doctorate.
Okay. Always good to have a doctor in class, but sometimes better. Okay, I am not sure all the things that lead to a stiff heart, so I'll get back with you on that one, okay? However, we haven't gotten here yet, but for those of you who don't know, probably you at least know it doesn't look all that good. I mean, if I said to you, do you want this rhythm, everybody knows enough to say, nope, not me. So people with diseased heart may lack the ability to compensate, okay? So when your patient calls you because their heart is beating too fast and you put on the monitor and this is what you see, this is not the situation where they're compensating, adding atrial kick, compliance, and other things that make the tachycardia not a dangerous thing, okay? Okay. So venous compliance, does everybody know what that means? So the veins, which are going into the heart, the more compliant they are, the greater the ability to expand, right? Okay. So what do you think? Venous compliance, if it becomes greater, if they develop more of an ability to expand, is preload going to go up or go down? What do we think? I heard a mutter.
Up.
Why?
If they can expand more, they'll push more in. So
Well, if they become compliant, it's almost like they become softer, right? They become greater ability to expand. So in this particular case, let's just make it really simple, okay? So here are the veins leading into the heart, okay? Arteries going out, okay? Now, the more blood flowing into the heart, the greater the preload. Does that make sense? Okay. If the veins become compliant, they're kind of like a reservoir, right? And they expand out and they expand out and they expand out and they expand out. That's, is about how the veins work. If they become more compliant and expand out more, do you think that's going to increase the filling into the heart or decrease it? Yeah, decrease it. Okay. So if the veins become more compliant, venous compliance, preload will go down. Okay, and this, I'm not going to go into it because we're not doing pharmacology, but when you get to pharmacology, when you get to nitro and some of the reasons why we give nitro, this will come up again. So if you remember, Hugh will think you're all really smart if when he says venous compliance, what happens with preload, you can all say, oh, venous compliance leads to decreased preload, okay? Okay, so again, we've talked about that enough. Okay, afterload, anybody remember that from A&P? Okay, afterload is not nearly as important a term for us as paramedics, which is good because it actually is kind of complicated. We're going to just take a very simple, quick definition of afterload. Okay, the resistance against the heart against which the heart must pump, and there's actually a lot of different factors into it, which is why it's complicated. For me, the easiest way to picture what afterload is if you think about the left ventricle. And somebody remind me, what's the valve called that goes from the left ventricle into the systemic circulation? Excuse me?
Aortic valve.
Perfect, okay? So think about, in order for the blood to go from the left ventricle into the systemic circulation, it has to open up that aortic valve. Sort of a quick conceptualization of afterload is the amount of pressure it takes to open that valve. That's the afterload, okay? Okay. Stroke volume. Let's see. Cody, stroke volume.
It is the volume of blood being produced out of the heart.
Okay. You're right. I just want to refine it a tiny bit more. Like, under what circumstance? Say it again, please.
In one contraction.
There you go. Okay? The amount of blood ejected by the left ventricle, or by the right ventricle, remember it's the same, during a single contraction. Stroke volume, it's the volume of one stroke, is a good way to think of it. One contraction. Okay? Cardiac output. Now we're going to take the concept of stroke volume and talk about and add time to it. So cardiac output is the volume of blood ejected by the left ventricle in what period of time? You can guess. Perfect. Okay. The amount of blood ejected by the left ventricle in 1 minute. Okay? Oh, okay. So now what we're going to do is we're going to talk about ejection fraction. Okay? That's what's coming up, is ejection fraction. And what I've learned is that's a little bit of a complicated topic. And so I'm purposefully repeating some things that we said about 10 minutes ago. So it's not like I've forgotten what I'm doing. That's why we're doing it, okay? So, Spencer, what is end diastolic volume? What does that mean? And what's the other word for it?
Preload.
Okay, and what does it mean, end diastolic volume?
The amount of blood that's in the ventricles before it is ejected.
Yeah, it's the largest, yeah, and it's the largest amount. Okay, so just so we all have it very clear, end diastolic volume, the volume in the blood in the blood in the ventricles at the very end of diastole, also called Riley. What else is it called?
Sorry, I'm in a fog. End diastolic volume, volume of blood in the diastole, the beginning of systole. I'm not sure. I'm sorry.
Kaya, help with that.
Preload.
Preload. Okay, that's why we do this. This is why we repeat it so that we can learn it. Okay, and then Anne, remind us, what is stroke volume, please?
The amount of blood the heart pumps in one pump.
Perfect. Okay. Now, let me ask you something. Okay, we know that the preload is the amount of blood at the end of diastole. Do you think the ventricles are ever truly empty? Like 100% like dry?
Mm-hmm.
No. So what that means, and you're right, I mean, that just seems so weird. What that means is really only a percentage of that end diastolic volume is going to be pumped out. And that's the idea that we're developing with ejection fraction. Okay, so here's the new idea. I just gave it away. It's ejection fraction, okay? So, Koa, what's a fraction?
Is a number over. Or,
Uh-huh. Yeah, you're right. What? Say it again?
When you have a number over a number, so it's.
Yeah, a number over another number. What's another way to say that? Okay, division. What else? Percentage. Perfect. Or ratio. Okay, so the first thing to know about ejection fraction is it's a fraction. It's a number over another number. It's a ratio. So if somebody says to you that's the ejection fraction is 20, already you know it doesn't make sense because it's not a fraction, it's not a percentage. Okay, so just know that when we talk about ejection fraction, we're going to be comparing this to that. It's a comparison. Okay? So what are the two things we're comparing? Ejection fraction is a comparison of the stroke volume, the amount that goes out with one contraction, to the preload, or to the end diastolic volume. And that should make intuitive sense because we just said it's impossible for 100% of that end diastolic volume to be pumped out. So with the ejection fraction, what we're asking is, with this patient, with this heart, what percentage of the end diastolic volume gets pumped out? Okay? So the ejection fraction is the percentage of the end diastolic volume, or preload, that is ejected out in one contraction. Now, Koa very accurately said that a fraction is one number over another. With ejection fraction, the first number is going to be the amount of the stroke volume, and the second number is going to be the amount of the end diastolic volume, or preload. Okay? Let's give an example, because then it always makes much more sense. Okay, Andrew, our end diastolic volume, and what's the other name for end diastolic volume? Preload. Is 120 milliliters, which is not a crazy amount for an adult male, okay? The stroke volume in this case is 60 milliliters. That's how much is going to get contracted out. What's the ejection fraction? Let me help you out. I think you did it upside down. Okay. Okay?
I did do it.
Okay.
Half, so
Okay.
5.
Yeah, remember, it's always going to be, it has to be a percentage, it has to be percentage, so 1/2. So in this case, we would say the ejection fraction is half, or 50%. 50% of the end diastolic volume got pumped out.
What would be considered a normal range?
Good question, and we will get there. Okay. So Grace, example 2, 120, 80, what's the ejection fraction? So Grace, what about this one? And I'll help you. Here, I'll help you out. It's 80.
3/4. 2/3.
2/3.
One of them.
Yeah, I know. It was a terrible one. Yeah, in fact, I used to, on the slide, put 3/4, and it took about 3 years for people to pick it up that it was wrong. Yeah. Okay, so ejection fraction in this case is 66%. So what is a normal ejection fraction? Anybody know? Okay, so what's considered normal? Of course, there's a range, because what does it depend on? When would you as a healthy person, when do you think your ejection fraction would go up? When you would be pumping out a greater percentage of blood every single time? Exercise. When we need it, okay, as a healthy person. Okay, so about 55 to 70% for an adult at rest, okay? And of course, it's going to go up if that adult is exercising. So how low is considered dangerously low? Because if you think about it, what about if only 10% got pumped out? What about if that heart just had so little oomph that only 10% got pumped out? Does that sound good? No, that's like really bad. So typically, less than 40% is considered cardiogenic shock. Okay, so that would be, okay, so do we actually use this? Well, not really, because I think it's an important concept for us to understand, but you think about what we're saying. We're saying, number one, we know how much is in the heart, and number two, we know the percentage that's pumped out. Are you going to be able to do that in the back of the ambulance? No. So the way that it's done is by something called a Swan-Ganz catheter, and it's a very, very invasive procedure, okay? So why do we need to learn this? I actually think while we can't measure our patient's ejection fraction, you're going to hear this, like when you go up to M&M or something, or when you hear doctors talking, you're going to hear about this idea of ejection fraction. So even if with your patient, you will almost certainly never know the precise ejection fraction, even knowing the concept of it is I think, an important one to know. Okay, moving along. Okay, 2 equations that I think are useful to know because they explain the relationship of things in the heart. Stroke volume times heart rate.
Cardiac output.
Excellent. Okay, and just as a reminder, Chris, what's stroke volume again, please?
It's the amount of blood pushed down the heart in one contraction.
Okay, and Spencer, what is heart rate? Oh, I guess we all know that. And what's cardiac output?
Stroke volume times heart rate.
But if I were to say to you, that's a perfectly good way.
In 1 minute.
In 1
the amount
minute,
of
right,
blood
okay,
being pumped
yeah.
out.
So remember, this is the number of times the heart contracts in 1 minute. This is how much goes out with each contraction. That's cardiac output. Okay, cardiac output times systemic vascular resistance. Okay, so how much the blood pressures are resisting the forward push of the blood. Anybody know what that one is? Yeah, excellent. Okay. And if we want to be really accurate, which for the purposes of this class we don't have to be, it's actually mean arterial pressure. Okay? And I think the value of these equations for us is not necessarily that we're going to plug in the numbers. I think it's understanding the relationship of these concepts. So for example, if you look at this equation and you say, let's say the cardiac output goes up, the amount of blood that's passing through the heart in a minute. If the cardiac output goes up and nothing changes with this, is the blood pressure going to go up or go down? Cardiac output goes up, but systemic vascular resistance stays the same. Ann? Yeah, so I think that's where the value of this is. Okay, 3 phrases that are useful to know as far as cardiac issues, but you will use much more commonly in pharmacology class, okay? But they're actually cardiac terms. Inotropy, anybody know? Okay, inotropy means pertaining to cardiac contractile force. If you have a drug, how many have heard of the drug epinephrine? Okay, so one of the things that epi does is it increases cardiac contractile force. It adds more oomph to the contraction. For that reason, we call epi a positive inotrope. You give epi and inotropy goes up, okay? Chronotropy. You might be able to guess this one because of chronos. Somebody knows, yes.
Rate.
Excellent. Pertaining to heart rate. What happens to somebody's heart rate if you give them epi? It goes up. So what do you think? Is epi a negative chronotrope or a positive chronotrope? Okay. And then this is probably the least used one is dromotropy, which means pertaining to speed of nervous impulse conduction. So electricity is moving through the heart faster. Okay. So epi is also a positive dromotrope. Okay. So when you give epi to a patient, it's going to increase the contractile force, it's going to speed up the heart rate, and it's also going to speed up the speed of nervous impulse conduction. Okay, how are you guys doing? We're going to probably go all the way through to 11:30. Do you want to take a little break or keep going? We have time for probably about a 5-minute break.
Do it.
Okay, 5 minutes. Okay. Okay. So here we go. So we're just going to have a little brief section about nervous control of the heart. So Natalie, what 2 components of the autonomic nervous system regulate the heart?
The SA and the AV nodes.
Here's your hint.
Oh, parasympathetic and sympathetic.
Okay. So the parasympathetic system and this, we'll get to the SA and the AV nodes. They're coming, okay? So who knows, I'll just throw this open because this is probably a more difficult question. What is the main neurotransmitter within the sympathetic system? Anybody remember that? Norepinephrine and principal receptors. Anybody remember what the sympathetic system? Alpha and beta, okay? Now, this is very generalized, but if we think about, especially if we're talking about cardiovascular system, the alpha-1 receptors, where are they mainly located? Anybody remember? I mean, there are many throughout the body, but a really big, important part of them. No? I mean, there are alpha-1, but that's not what I'm fishing for. Yeah. Nope. Nope. so located in the peripheral blood vessel. So when alpha-1 receptors are stimulated, they promote constriction. Okay? So among other things that we talked about with the epinephrine, one of the things that alpha-1 does is that epinephrine does is it stimulates alpha-1 receptors. So this causes the blood vessels to constrict. So when you give epi to your patient, is their blood pressure going to go up or go down? Up, because of the blood vessels are constricting. Now, beta-1, again, they're located in many parts of the body, but for our purposes, and we are talking about the cardiovascular system, where are the beta-1 receptors located?
The heart.
the heart, okay? And when you stimulate beta-1 receptors, you get increased chronotropy, heart rate, increased inotropy, contractility, and increased impulse conduction, dromotropy. So when we talk about epi as a positive chronotrope, inotrope, dromotrope, that's because epi also stimulates the beta-1 receptors. Yep.
So when people take beta blockers for chronic tachycardia.
Yep. A lot of times for blood pressure.
Blood pressure.
Yeah. Okay.
So what all that's doing is just somewhat blocking those receptors? Like they're not
Yes,
obviously not
yes,
completely
yes, that's
blocking.
exactly what it's doing. So it's not allowing the heart rate to go up, because if your heart rate goes up and nothing else changes, your blood pressure goes up. Okay, yeah, great question. Okay. And then the only other sympathetic receptors we're going to talk about are beta-2, are primarily located in the lungs. Beta-1, one heart, beta-2, two lungs. Okay, that's a good way to remember. Now, they do other things, but for the purpose of the cardiovascular system, beta-2 are located mostly in the lungs, promotes bronchodilation. Who are your patients that really need bronchodilation? What type of patients? Yeah, and do you know what the most common drug that first-line drug we give them? Albuterol. Albuterol stimulates beta-2, okay? Okay. So to reiterate, stimulation of beta-1 receptors in the heart increases sympathetic tone, and all of these things go up, and I'll just let you read that. So the parasympathetic system actually innervates the heart by one of the larger nerves. Anybody remember what it is? Yeah, excellent. Vagus nerves. What neurotransmitter in the parasympathetic system? Perfect. And principal receptors based on the term cholinergic. Okay? So, stimulation of the vagus nerve increases parasympathetic tone. So what do you think, don't worry about the essay note, we'll get to that. What do you think happens to the heart rate when the vagus nerve is stimulated? Up or down? Down, okay. Force of contraction, up or down? Down. Okay, so anytime that parasympathetic tone goes up, the opposite thing happens to sympathetic tone. So all those heart rate, contractility things that go up with sympathetic tone go down with parasympathetic tone. Okay? Okay, moving on. Like I said, that part was going to be really brief. Okay. Now, the primary function of cardiac myocytes, Como, what does myocytes mean?
Muscular cells.
Yeah, muscle cells, is to contract. That's why we have a heart. Remember, pump equals heart. So what we want are the myocytes to contract. In order for that to happen, what causes that is electrical changes. So first we have electrical activities. Now we're finally getting into ECG land. First we have electrical activity that moves into mechanical activity. Okay? There are two basic types of cardiac cells: contracting cells and conducting cells. Now, this is really misleading, I think, or slightly, but I think it's really misleading, because the contracting cells also conduct electricity. But when we talk about the conducting cells, we're talking about the specialized ones, the ones that do it really well, really fast. Just remember, all cardiac cells conduct electricity to some extent. Now, the contracting cells, those cells that are just sort of the basic workhorse cells of the heart, form 99% of the cells in the atria and the ventricles. So most of the cells in your heart, their job is just to contract, okay? They do conduct impulses. Like I say, it's misleading to say they're not conducting, because they also conduct. And they're responsible for the contractions that pump blood through the body. The conducting cells are only 1% of the cardiac cells, but in this class, those are the ones we're most interested in, because we're interested in ECG, we're interested in electrical activity, okay? These are only 1% of cardiac cells, and they have various jobs. Number one, they initiate the electrical impulses that go through the heart. So they act as pacemakers, okay? But they also transmit electrical activities at crazy fast speed through the heart. That's why they're specialized. They initiate the impulses and then they conduct them, these specialized cells, very, very, very fast through the heart. And these specialized cells, one of the big differences is that even though all cells conduct electricity, the specialized ones do it much, much faster. Now, we can't talk about cardiac function without talking about electrolytes. The three most important ones, not the only ones, but most important ones are sodium, potassium, and calcium in the heart. And we're just going to go through it kind of briefly here. Sodium plays a major role in depolarizing ventricles and atria, myocardium. Potassium plays a major role in establishing resting potential. And if you're thinking, oh, that sounds familiar, but I don't quite remember, in a minute we're going to talk about resting potential. And a major role in repolarization. Again, we're going to talk about it in a minute. Calcium plays major roles specifically in the SA and AV nodes that we'll talk about soon, and also a major role in myocardial contraction. Who remembers resting potential? Anybody remember that term from A&P? Are you nodding yes, Chris?
I remember the words.
I guess that's what I asked. So the answer is who remembers? Yes, I remember. Okay.
Like the resting electrical activity that's going on before depolarization and contraction.
Yeah, okay. So it's the electrical potential difference. So remember, all cells, all cardiac cells have a membrane, okay? The resting potential is the difference outside to in when, as you say, the cell is just resting. It's not depolarized, it's just sitting there, okay? But when it's just sitting there, what has happened is there is a change, different ions. There's some ions that are very, where lots of them are on the outside, and some where there are lots of them on the inside during resting potential. In a minute we'll talk about what those are. So if that's resting potential, anybody remember what action potential is? It's obviously the opposite of resting potential, but
Is that the threshold that it needs to reach to be able to send an electrical pulse down max?
yeah, pretty much. So it's the rapid rise and fall in voltage across a membrane, okay? It's when things change. Everything's hanging out, resting to potential, and all of a sudden things change, okay? And cardiac depolarization, I'll just give you this one, is the rapid reversal of charges that a cell membrane so that the inside becomes positive relative to the outside. So we're going to go through these definitions and then we're going to get very particular, okay? So we'll just kind of run through the definitions and then we'll get very specific. And repolarization is after depolarization, the cell has to return to resting potential. And it does that through repolarization. So there are 5 phases of cardiac depolarization, okay? So there's 0, 1, 2, 3, 4. And we'll come back, let's come back to this. This is what it looks like. I like to start with 4, which sounds, why would I start with 4 when it's the highest number? But it makes most sense to me because phase 4 is the resting potential, okay? So we're going to start there. Now, here's what you need to know. During resting potential, we have these sodium potassium ATP pumps, which I'm sure you remember, but for our purposes, all you need to know is that with, given ATP, given energy, what's happening in the cardiac myocytes is they're pushing sodium out in exchange for potassium. And it takes energy, it requires energy to cause those concentrations. So at resting potential, we have a number of potassium ions on the inside and a number of sodium ions on the outside. And you need to know that, okay? You need to remember, sodium on the outside, potassium on the inside. But there's a change of voltage, and if you look right around the inside of the cardiac cell, it's more negative right along the inside as compared to the outside. Now, you do need to know that at resting potential, it's more negative on the inside. You don't have to know minus 90. That's typical for ventricular cell, but I don't care about numbers, just concept. So on this slide, there are two things you need to know. At resting potential, more potassium on the inside, more sodium on the outside. In terms of electrical charge, more negative on the inside, more positive on the outside. Okay? That's what you need to know. Now, I think we're going to stay here for just a minute. Now, the sodium would really love to get inside the cell for two reasons. Number one is that ions will follow what's called their chemical gradient. Remember we said lots of sodium on the outside, very little on the inside. So what it really wants to do, it's like, like virgin territory. It wants to go inside. So it can't go inside during resting potential because all of the gates that allow sodium to enter are closed. But boy, does it want to go inside because it wants to follow its chemical gradient. There's a second reason why sodium really wants to go inside, and that's that it is a positive ion, and all along the inside is a negative charge. So there's all this pressure building up for sodium to go inside the cell, but because the sodium gates are closed at resting potential, it can't. Okay, to repeat, all cardiac cells have a resting potential which is negative on the outside. And again, you don't need to know absolute numbers. This is, you don't really need to know this. I'll run through this pretty quick. The negative potential is maintained by a number of different things, and I'll show you a picture in a minute. This is kind of extra information, not totally necessary for you to know. What keeps the minus 90, what makes it negative on the inside is, first of all, the cell is always pushing sodium out, potassium in. But potassium can actually get out because there are these little gates that allow, even at resting potential, for the potassium to flow out, okay? So it's flowing out, flowing out, flowing out. It's also being pushed in. It's a dynamic system. Because we have a positive charge going out, there's a lot of protein inside the cell. Proteins tend to be negatively charged and large. Well, because they're negative, they would love to follow that movement of the potassium, of the positive ion. But potassium ions are tiny. These are big. They're going out through little tiny gates. So all of this negatively charged protein is moving there and it stops. And that's one of the things that's creating this negative environment along the inside of the cell. Okay, here we go. So that was resting potential, phase 4, okay? Depolarization is phase 0, okay? The cell receives a little impulse from a neighboring cell. It bumps it. And when it bumps it, it raises the resting potential just up a little. That little bump from the neighboring cell raises it from minus 90 to minus 70. Again, no need to know the numbers, just the concept, okay? That opens the sodium channels. Do you remember what I said is how much the sodium wants to get in? It's like a tsunami. It's like this sodium is just itching to get inside. And when the gates open, it's like this tidal wave of sodium moving to the inside. It's very dramatic on a, on a molecular level, okay? And what happens is that, remember, it used to be minus here, along the cell, minus charge, negative charge. Well, all that sodium goes inside, bumps the charge up to positive, to plus 30. Absolute number's not important. So that's depolarization, is this opening of the gates, the sodium flooding in, and the charge goes from negative to positive. That's what this is, okay? So this is charge, negative, positive, happens very, 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 very quickly because of sodium gates opening up. Okay. Okay, and then the plateau phase, the next phase is phase 2. We're really not all that interested in phase 1. I skipped over phase 1. That's the, if you remember, let's go back a minute. This is phase 1. This is 0. This is 1. We don't care about phase 1, so we're just going to skip over. It's not important for ECGs. It's not important for pharmacology. But phase 2, that plateau phase, is a bit important. So the prolonged plateau is the extended refractory period. What does refractory mean? What's refractory period? What does that mean?
It's like a recovery.
It is recovery, but it's a very special kind of recovery. It's a recovery, the cell is refractory, meaning that even if it's hit by, refractory means it's not going to respond. If you have a patient who is refractory to your treatment, it means that your patient is not responding. If the cell is refractory, it means even if it gets hit by another impulse, it's not going to depolarize again. It's protected from depolarizing. Okay, and it's that plateau that's going to allow atrial and ventricular contraction to happen. That space where the electrical activity is just holding steady, it's like, okay, now the contraction is going to happen. That's there. And then repolarization is phase 3, is that what happens is the whole thing starts reestablishing itself. Sodium, which has flowed in, is now being kicked out again by the ATP pumps. Potassium is being pushed in, and everything reestablishes back to phase 4, the resting potential. Okay, so to repeat a few, it's a complicated, I've thrown a lot of details at you, but just to repeat some things that are important. During depolarization, who remembers what kind of channels open? And what kind of channels flood into the cell? Sodium. Yeah, same thing. It's sort of a trick question because you think, well, it couldn't be the same. Okay, this is a super important concept for paramedics, and I'll tell you why in a minute. Refractory period, remember that was that plateau, okay? The period of recovery that the cell needs after being discharged before they are able to respond to a stimulus, okay? It's repolarization, but it's the special part of repolarization where even if it gets hit by another electrical impulse, it's not going to respond, okay? There are 2 parts of the refractory period, and we're going to talk about these in some length, not just this class, but in other class periods. Absolute refractory period, no matter what, okay, no matter how much electricity you hit that cell with, it simply cannot depolarize again. It can't, the charges won't change, it just sits there, okay? So very briefly, how does this happen? This is our sodium gate, okay? Here's inside the cell, outside the cell, here's the membrane, here's the gate, okay? The sodium channel. This is resting potential. Who remembers during resting potential, are there more sodium ions outside or inside? Outside. And what's the concentration of positive ions on the inside? What was the other one? Potassium. Okay, just a little reminder. It actually doesn't matter for this. Okay, so the reason sodium is built up is the sodium channel, it's closed. It's trying really hard to get in. It can't. The sodium channel is closed. Okay? So then, the cell gets its bump from the neighboring cell. And what that does is it raises the charge up a little bit, just enough so that the gate opens, sodium goes flooding in, okay? Action potential from neighboring cell raises membrane potential, sodium gates open, sodium rushes in, that's depolarization. But these gates are really complicated. Not only do they have, here's the open shut part of the gate, it has a secondary part, which is called the inactivation gate. You don't have to remember that name. You can just think of it as the plug at the bottom of the sodium channel. At this period, right after the sodium rushes in, the plug at the bottom, the inactivation gate, plugs the hole. Okay? And even though this is open, you would think sodium could go in. It can't because of the plug. And not only that, no amount of electricity is going to unplug that plug. So even if the cell is hit with a ton of electricity, it's not going to affect this, and sodium will not be able to go in, so the cell will not depolarize. Then eventually what happens, the cell returns to its resting potential. This opens, this closes. Now it's ready to be depolarized. All set to go. We're back at resting potential. Now, here's the important part. Now, again, I'm going to circle back and tell you why. You're probably thinking, why do I need to know this as a paramedic? In a minute, you'll know. Okay? So, when all or most of the inactivation gates remain closed, the cells are in absolute refractory period. And that's good, because the heart's not ready to depolarize again. There's a danger period. Okay, and that's what you need to know about. When some of those inactivation gates, we're thinking of the whole heart now, some are open, some are shut, then some of them can depolarize and others cannot. The important thing to know about the heart, what keeps things in line and healthy, is synchronized, specific means of depolarization and contraction. Things go haywire, and in a minute I'll tell you what I mean by haywire. Things go haywire if some of it's working and some of it's not. That's a bad way for a heart to operate. We want it to all operate as one. We don't want some of it to be working and some of it not. Okay? So that period is called relative refractory period, when some of the heart is ready to depolarize and some is not. Why can the relative refractory period be a dangerous period for the heart? Yes?
Because everything's shooting at different times?
Yeah, or if it's given a stimulus, it could all shoot at different times, okay? When the heart is all going at different times, anybody know what we call that? Keeps you in business. What was that? Yeah, fibrillation, okay? So we call that VFib. If a strong enough stimulus causes only some cells to depolarize, the result can be chaotic electrical mechanical action. Now, I keep saying this is important for paramedics to know. Does anybody put it together when you have the opportunity to cause VFib in your patients?
Shocking.
A specific kind of shocking.
Pacing?
What was that?
Pacing?
No, you're almost there. Anybody heard of synchronized cardioversion? Okay, so briefly, and if you haven't, don't worry about it. You'll hear about it a lot this year. This is just the first little toe in the water mention, okay? So if, let's say, you will come on your patient and somebody is in VTAC, okay? And you think, oh, I've got to treat this patient. One of the most effective, and even though we haven't talked about what ventricular tachycardia is, I think you all recognize it as something bad, okay? So one of the most, and this is somebody who is sitting there talking to you. So they have a pulse and they're in VTAC. But you want to get them out of the VTAC, okay? Because you don't want them to go into VFib. So one of the most effective strategies is to hook them up to the monitor. And it's not pacing, it's one shock, like defibrillation. It's not as high joules as defibrillation, but it's a pretty good, they'll feel it, and it'll hurt, okay? And the idea, hold tight just a second, the idea is that you're gonna stop everything in the heart, meaning stop the VTach, and hopefully a normal sinus rhythm will come back. So it's very effective treatment. However, if you happen to shock them during the relative refractory period, instead of going into a normal sinus rhythm, it could go into VFib. If you hit them at the wrong time, some of the cells could fire off and some could not, okay? So when we synchronize, what we're saying is we're telling our very smart monitor, you're saying to the monitor, hey, look at this patient's rhythm and be sure and hit them not during the refractory, the relative refractory period. Okay? And that's not, so when you sync, you're telling the monitor to hit the patient with electricity during a particular moment. Okay? And it's not a theoretical worry. Fortunately, I've never been on scene when it's happened, but I have heard of people who forgot to sync and put the patient right into VFib. In that particular case, it was still a happy ending. I'm not so sure for paramedics, but it was for the patient, because they immediately turned around and they did the wrong thing, but immediately turned around and did the right thing, was defibrillate the person, and they came back. So, yeah.
I think it's my own question in my head, but the relative refractory period is when you can still shock and certain cells will respond, whereas the absolute refractory period is when it's
Nobody.
yeah,
No.
nothing
Yeah,
can do.
and that's when you want to hit them, because you just want to knock everything out. And you want everything to stop. You don't want some things to start and some things to stop.
Right, which was great.
Yeah.
Does the relative refractory period always happen, or is that when something's wrong?
No, it always happens.
Okay,
It always
so-
happens.
So I just have to hear it one more time.
Yes.
Relative refractory is when some of them are relaxed,
Mhm.
and then some of them are getting to that relaxed state.
I
It's not
think
charged.
I think it's better not to think of them as some of them are relaxed. I think of them as think of it as some of them are able to respond to an electrical stimulus, and some of them are not.
And they're not yet, just because they haven't had enough time.
Yeah, that's correct. That's correct. So we think of the heart as very coordinated, and it is. So this is all such fractions of seconds, right? But they sort of come back online, if you will, say, okay, now I'm ready to be depolarized at very slightly different times throughout the heart. And what you want is them, when they depolarize, they all should be ready to depolarize. And when you hit them with a shock, such as cardioversion, you want them all to be an absolute refractory period, because you don't want any of them to respond. You just want to knock everything out. Yeah.
Can you explain again how they can sync up to when the absolute refractory period is occurring? Is that via
Yeah.
machine? Is that the actual cardioversion machine?
Yeah, I can sort of do it. I can do it, I can explain how they would sync in a regular, I'm not 100% sure how they do it in VTach.
Mhm.
Typically, when we get talking about it, and this will be next week, so I don't think I'm going to be able to draw it because we haven't gotten there yet. When we look at a normal ECG, there's a P wave, there's QRS, there's the T wave.
Mhm.
There are all these parts of the ECG. And the relative refractory period tends to be at the end of the T wave.
Okay.
So if you were syncing to a sinus rhythm, essentially you're syncing to anything but the end of the T wave. I don't know specifically how they do it with VTach, but I assume it's similar. They're actually, even the VTach sort of looks like all the same thing. There actually is a QRS and a T wave, and I assume it's just avoiding the T waves.
Okay.
So. Okay, oh, we might finish. I thought we might not, but this. Okay, now the irony of this rather long, tiring lecture is the most important part is at the very end, when everybody is half asleep. So I will tell you that, but it's also information that we are going to go over and over and over again, multiple times, so you'll learn it. And that's why, if you remember, we looked at the to-do list. I have you watching a little 10-minute video, and that's reiterating what we're talking about now. Okay, and we'll go over it so many times you'll get it. But anyway, just to say, this is actually the most important part. So where is the starting point for the impulse that travels through a healthy heart? Where does all this electrical impulse stuff start? What is the pacemaker for a healthy heart?
So the SA node?
It is, in fact, the SA node, okay? And this is the conducting system, and we're going to kind of work our way through it. The conducting system is made up of that 1% of specialized conducting cells that conduct really, really fast, okay? That's what it is. When we talk about the conducting, this is that 1% there, okay? The SA node, sinoatrial node, is in the upper right corner, there's no real corner, but the upper right portion of the right atrium, okay? It's an actual structure. It's not just a little cell. It's a complicated little structure. It is the main pacemaker of a healthy heart, meaning that's what's driving the depolarization that leads to contractions. However fast the SA node is shooting out impulses, that's the heart rate. If it's shooting out impulses at 60 a minute, eventually it's going to translate into 60 contractions a minute. Okay? Located in the upper right atrium, at rest, this should be covering here, so you're off the hook because it somehow got moved. At rest in the body, the SA node has an intrinsic rate of self-excitation of 60 to 100. Yeah.
So when someone has an artificial pacemaker, is that just taking over the role
Yes.
of the SA node?
Yes,
Okay.
yes, yeah, yes. We'll just leave it at yes.
Vaguely.
So, okay, so that didn't make any sense. So, like I said, here's the SA node is actually a really complicated. This is from, what is it from? An 8-year-old female beagle dog. It's the region surrounded. Here's the endocardium, epicardium. So you can see it's not just a little thing. It's a very complicated little structure. And for our purposes, that's really all we need to know, is that it's complicated. Now, explanatory note, okay? The impulse leaves the SA node and goes flying down the specialized conduction system in the atrium. There's sort of these tracks that exist in the atria of the specialized conduction system. Throughout the heart, there is a very particular way that electricity spreads. And for you to understand what happens, I really can't emphasize enough, it's important to understand what I'm saying now. This is the myocardium. So these are all those regular 99% contraction cells, okay? As mentioned, they can also conduct, only slowly, okay? This represents the conducting system. The SA node's up here somewhere. This impulse travels down the conduction system unimaginably fast. And so what that means is all of a sudden, there is this little portion of depolarized strip kind of going down the middle of all this real estate here, whatever this is, atria, ventricles. It gets to here, but when it first starts out, let's go back. When it first starts out, it's just going to be that red line and nothing to the outside of it has depolarized. But look at the yellow. So what happens is the impulse gets carried down the conduction system and then it spreads out from that point, okay? The importance of this is that if we just started here and moved down, the only way, if there was no conduction system, the depolarization would just start at the top and gradually move down, move down, move down, move down. But if you look at the way the heart depolarizes and how it contracts, the job of the conducting system is to deliver electricity to certain parts of the heart very quick. And in that way, it's able to orchestrate how the depolarization occurs and how the contraction occurs. So it's a very sophisticated piece of three-dimensional engineering. Without the conduction system, everything would just be pushing down. But does anybody know how does the ventricles contract? From top to bottom or bottom to top? Bottom to top, bottom to top. It's like the bottom of the ventricles start contracting first, and they squeeze the blood up because the aorta and the pulmonary trunk are at the top. Well, but if the impulse is coming from the SA node, how do the ventricles start contracting at the bottom? And the answer is the conducting system sort of throws the electricity down there, and then it spreads out from that point, okay? Okay, the impulse leaves the SA node and speeds through the conduction system. So here's the specialized tract. There's one that shoots over to the left atria called the Bachmann's bundle. You don't need to know the name, okay? So that allows the left atria to depolarize simultaneously with the right atria, okay? So the conduction system goes flying down the atria, ends up in the SA node. What happens to the electricity at the SA node? AV node, I'm sorry. Does anybody know?
Delayed.
Good, it delays. There's a pause here, okay? All this electricity comes flying down, and meanwhile the impulse is spreading out through the atria, allowing the atria to contract in a very coordinated way. Why do we have a pause at the AV node? Yeah. Anybody?
No, go for it.
To allow the relaxation of the atria and ventricles.
Well, yeah, to allow everything to catch up, to allow the systole of the atria, the blood to get down to the ventricles. It's like the atria get depolarized, contract, waiting, the ventricles get depolarized and contract. Okay. 3 special qualities of the AV node: only electrical pathway between the atria and the ventricles, electrical impulses pauses, and also that limits the rate of transmission from the atria to the ventricles. We'll come back to that. There's only one way for the electrical impulse to get from the atria to the ventricles, so that's through the AV node. Okay, every other place is non-conductive tissue. Okay, it's the only way for electrical in a healthy heart. Okay. Okay. I'll just let you read this. Okay, this ensures that the atria have ejected the blood into the ventricles. Atrial kick. I think you can read this. We'll come back to this. It's kind of an important concept, but we don't quite have time for it, but we will do it. Okay, here is what happens after the AV node is that the conduction system continues, and it what's called the bundle of His is the conduction system that's right below the AV node. It then bifurcates into the left bundle branch block and the right bundle branch block. It then divides up into little tiny fibers called the Purkinje fibers that, again, their job, these are part of the speedy conduction system, delivering electricity to parts of the heart. Let me just